Thanks for being here. We got folks from all over.
Okay, we are going to go ahead and get started. I'm going to mute everyone so we don't have any interruptions. So please don't unmute yourself unless you're a speaker. But feel free to continue introducing yourself and where you are in the chat. We Alrighty. All right, I've got all of you muted. I've taken over. Welcome, everyone. My name is Liz Fry. I am the chair of the board of directors of the Street Medicine Institute, and we are just thrilled that you all are with us today. We will probably have more people joining kind of as we go through in the next 5 or 10 minutes or so, but we wanted to go ahead and get started because we have a lot to share on our webinar today. I want to let you all know that we are recording and we will have in the recording our speakers spotlighted, so your videos should not be recorded, but we invite you to keep your cameras on if you want to. We're going to have the panel speak for about an hour going through the encampment report that was written by Caitlin Schwann and others in the California Street Medicine Collaborative. And I want to go through just kind of a few announcements as we are just getting started. So if you'll bear with me, I appreciate it. All right. So this is the first in a multi-part or series of webinars that the Street Medicine Institute is hosting. We have the pleasure this time of co-hosting with the California Street Medicine Collaborative, led by Caitlin Schwann, who is also on the board of the Street Medicine Institute. If you are interested in participating in anything else the Street Medicine Institute has to offer, including future webinars, which we have not scheduled but will announce in our newsletter, feel free to use this QR code, or you can visit streetmedicine.org to sign up for the newsletter. This QR code will take you directly there. And I think that we are going to put the link in the chat as well if you want to sign up that way. Thank you, Suzanne. All right, next up, we have announced this already earlier or late last year, but we are having our International Street Medicine Symposium in Hilo, Hawaii this year. It'll be in September, and I think it's going to be really, truly fabulous. It's hosted by folks from Hope, and they are predominantly a Native Hawaiian organization working to care for the people sleeping outside, I believe on all of the islands of Hawaii, but I may be wrong about that. So I hope that all of you will join us. Well, honestly, yes, the number of people currently on the webinar could join us. We have 800 or 800. We have 184 people, but we only have about 400 seats at the symposium. But it's going to be a great one. All right, last slide for me. I want to go through our community agreement. I wish that I did not have to share this at all, but I think in many places in our world right now, our communities have become less safe for a variety of reasons. And because of that, we want to make sure that we're all on the same page and being respectful of each other and of our speakers, and most importantly, the people who we're serving, the people who live out on the streets, and people who are with us who have that lived experience of sleeping outside. So I'm just going to read through this, and I hope that you all will find that this agreement is both reasonable and a way to keep all of us safer. So we ask that we all treat each other with respect, dignity, and consideration in the spirit of valuing diversity of views and opinions. Be considerate, respectful, and collaborative in your communications and actions. Refrain from demeaning, discriminating, harassing, and disruptive behavior and speech. We will have a Q&A during the last 30 minutes of this session, and I ask that you please stay muted until you're called upon. Report if you observe any violations of our community agreement, please report them via direct message to me in this webinar. I'll be looking out for it, or via info@streetmedicine.org after the webinar. Any reports will be investigated, and violations of our community agreement may result in expulsion from the webinar and/or termination of Street Medicine Institute membership. Again, I hate having to say this, but I think it's worth making sure that we're all in a safe and respectful environment. And should anybody pop on the webinar that we don't want on, then we'll be able to move onward and keep this community wonderful. All right, I am going to turn things over to Caitlin Schwan, and she is going to get us started. I will let her introduce herself.
Great, thanks, Liz. Hi, folks. It's just so wonderful to be here. We were overwhelmed. Over 700 folks signed up for this webinar. So there's obviously such a need for this conversation. What we're hoping to talk about today is really how to protect the health of folks who are living outdoors and are being displaced. And the language around that really differs community to community. Sometimes folks talk about displacement, talk about sweeps, talk about clearings, but we're really talking about the forced displacement of folks who are living outdoors, their possessions, often by government actors or other actors. And as all of you know, we're living in a very particular moment. We've seen a huge escalation over the last 8 months around encampment displacements and sweeps. And it's really transformed street medicine. It just really has. Practitioners are losing patients. We have new challenges in terms of clinical care, unbelievable levels of trauma, and some of us are losing our patients to these practices. So what we did in California, I lead the California Street Medicine Collaborative. We decided to come together and really try to develop a practice guide around encampments and street medicine. And the goal was to be able to provide practitioners with really concrete strategies for how do we reduce the harms of sweeps on our patients and how do we protect the health of our patients. And that's like before sweeps, during sweeps, after sweeps. And we're very excited to share it with you today. We're launching it today here with all of you. This is what we're going to run through with you. I'll give a very brief background. We'll get right into the nitty-gritty with the practice guide. We're going to give some great research that's been done on the health impacts of encampment displacements and sweeps, and then talk about strategies for care in that context. We also have our friends from New Haven and Kansas City who are going to share some reflections, some lessons learned from their work, and then we'll get into our Q&A. So think about questions you want to hear answered from this group. This is our brilliant group. I'm very excited to introduce them. So first up, we have Dr. Kyle Patton. He's the Medical Director of Hope Program at Shasta Community Health Center in Redding, California, where he leads a harm reduction and client-focused approach to care. He's trained in family medicine with a supplemental street medicine fellowship and provides full scope primary care to folks experiencing homelessness. You are also going to hear from Dr. M.K. Orsolak, who is an assistant clinical professor in the University of California, Davis, Department of Family and Community Medicine and Addiction Medicine Division. She's developed and delivered care through innovative street and mobile medicine programs in Sacramento, California, and is really committed to improving access and quality of care for folks living outdoors. I was able to go out with MK on the street, just a beautiful practitioner. We have the brilliant Emma Lowe, Dr. Emma Lowe here. She's the medical director of the street psychiatry team at the Connecticut Mental Health Center in New Haven, Connecticut. She is also faculty at Yale as an assistant professor in psychiatry. We also have our friend John Kulik here, who's going to speak with us about his experiences. He's experienced homelessness for 13 years and is now a substance use disorder counselor for the Village Initiative in Kansas City, Kansas, providing wraparound services for folks who are transitioning out of incarceration. He's also on the board for Care Beyond the Boulevard in Kansas City, Missouri, and treating all clients with compassionate healthcare. And then we have me on the bottom there with my wonderful friend and all of our friend, Jim Withers. I'm not a clinician, but I have a PhD in social work. I've been doing international human rights law work for a number of years, but fell in love with street medicine, so decided to come down and support this movement. So that is the crew we're with today. And this is the report we're launching. I'm going to ask Suzanne if she could drop a link in the chat. This is our practice guide. We developed this, the California Street Medicine Collaborative and USC Street Medicine in partnership did this work and excited to launch it with SMI. It was developed in the California context, but I really think it's highly adaptive nationally. And so really encourage you to take it, use it, adapt it for your context. And we also did this cool little kind of pocket guide. It's meant to be something that you could print out as a postcard or put up in your office. Just gives you kind of high-level strategies for care in the context of encampment displacements and sweeps. Very quickly, I don't know, I suspect the audience here is very familiar with the context in which all of us are working, but just wanted to say, why did we write this report? We really are seeing a significant shift towards the criminalization of homelessness across the country and an increase in bans against living outdoors. As all of you folks will know, in June of last year, we had the Supreme Court's ruling in Johnson v. Grants Pass that permits governments to prohibit sleeping or camping outdoors, even if there are no shelter beds available. And since that decision, across the country, we've just seen like a wave of state and municipal governments who have adopted policies in alignment with that. Certainly true in California. And, just speaking in the California context, real increase in zero tolerance policies, huge loss of patients across street medicine teams, governments hiring private firms, to do security and encampment removal. There's really considerable financial and criminal charges that folks are facing. So this is the moment we're in, and this is the moment we are trying to speak to with the guide. And to be very clear, the intent of the guide isn't to assume the inevitability of these sweeps or to replace the kind of advocacy work that we need to be doing on the policy level around this, but it's to acknowledge that these sweeps are ongoing. We need to be equipped as a movement with a reality-based harm reduction approach to this work, and that's really what the guide is about. And the last thing I'll share here, hold on a second, is our methodology. This was really fun. The way this guide was built is at our statewide symposium, we had street medicine practitioners, allied professionals, folks with lived expertise, all together, a big room, and we did like what's called the World Cafe method, doing a lot of community consultation on what are the health impacts, and then what are street medicine teams across the state doing to mitigate those impacts of the sweeps and displacement we're seeing. We combine that with a scoping literature review and also a bunch of kind of key informant interviews. The result was this practice guide, and I would just invite you to see it very much as a community knowledge product and something we collectively own and we pass on with a lot of love to the movement for your use. Yeah, that's great. So I'll pass it over to my colleagues to take us through this beautiful piece of work.
Thanks, Caitlin. I'm Kyle Patton. I'm not from, but I'm practicing here in Redding, Northern California. It's really great to be with you guys today, to talk through the guide and introduce this to all of you. It was also great for me to be able to participate in the writing and formation of this guide. I think for those of us that are out on the street doing this work, being confronted with encampment sweeps and seeing how that impacts our patients has been really demoralizing for me, and I think a lot of my other street medicine colleagues. So it was really a positive experience to be able to sort of like take some of this back and dig deep into our diverse expertise and come up with a guide that I feel is really comprehensive and nuanced in giving all of you guidance in how to navigate these challenges. Just in way of introduction of the guide, I think we're going to be putting up a link to the guide in the chat. At some point, I would encourage all of you to go read through the entirety of the guide. We really tried to have a lot of just reality-based, harm reduction focused strategies that all of you can use. And unfortunately, just given time constraints, we're not going to be able to go through all of those during the webinar today. We'll give you kind of like the key points and try to hit those that we thought were sort of most important within the guide. But really take some time to read through it because there's a lot of good strategies, like I said, but then also some good case reports and different ways in which you can apply it to your community. Keep in mind too, this is also a guide, right? So what works for one community isn't necessarily going to work for all communities. This is not a one size fits all. You know, some communities are going to get out there in front of the bulldozers and like stand there and be there in solidarity for their patients. That doesn't necessarily work for us here in Reading, just given some of the political climate, some of our limitations in resources. And so, you know, we're going to take a different approach. So we also try to acknowledge that people's communities are different and tried to navigate some of those recommendations with nuance to give people the freedom to be able to say, like, this is what's going to work for us in our community. When you go through the guide, you'll see that it's organized in a certain way, and we sort of split it up between people's sort of activities before sweeps and how you proactively plan with your patients to help them find safe shelter or to navigate to another place that's safe. That also includes navigating some of like their medical vulnerability and coming up with treatment plans that are sweep resilient and some other things. There's day of considerations, like the main sort of question along with that is, do you or do you not be present on the day of the encampment sweep? And we spent some time in the guide sort of discussing some of the sort of downstream issues related to that. And then there's how do we mitigate harms after the sweep? How do we re-engage with our folks? How do we find them? How do we really just try to maintain that sort of long-term continuity of care? And keeping in mind, like throughout all of this, wherever you're at in sort of that timeline, you know, we're really just trying to maintain continuity, maintain that sort of like longitudinal communication and support for our patients. So with that, let's jump into it. I'm going to pass it over to MK, who's going to talk about some of the health effects related to this.
Yeah. Hi, everyone. Thanks, Kyle. So the way we're going to move through the next section is going to talk about the health consequences of encampment sweeps and then the strategies to help mitigate them. With the ultimate strategy being to stop sweeping. But we know that encampment sweeps lead to harm, they lead to negative health consequences, and all of this contributes to death. And so one of the ways that encampment sweeps lead to harm is by creating the loss of personal belongings critical to survival. And so I want to highlight the quote here. that says, if you wanted to design an epidemic, repeatedly taking medications away from an entirely vulnerable population would be an ideal way to start. And that is exactly what encampment suites do. As street medicine providers, we work in tandem with our patients to try to get medications to them to help treat chronic medical conditions, and time again have seen them thrown into the trash during encampment sweeps. Other things also are thrown away during sweeps: IDs that take a long time to get that are necessary to be registered for many things, vital documents, birth certificates, things like that. Phones, which are important to connect to a lot of different things, each other, community, healthcare appointments, family, etc. And also survival supplies. And I think of survival supplies as a broad term. It is things like, yes, tents are thrown away, tarps are thrown away, sleeping bags are thrown away, which are all necessary to protect from the elements when living outside, but also the things that are important for like your heart and surviving. And, Caitlin and I were talking about this yesterday with Kyle. So we've heard stories of family members' ashes being thrown away, family members' photo albums that kept people feeling close to their community being thrown away. And so the harm is big, and it continues to grow. Now we can pass it on and talk about some ways to mitigate these consequences.
So here's some strategies to kind of navigate some of the loss of personal belongings. So I moved to California 5 years ago from Texas. I was practicing in Texas, and I thought I was going to get great California weather. The reality of that was very different, namely because I moved to like the northern Central Valley where it's very hot. But we've seen, pretty much since I've moved here, and we've been seeing increasingly more severe weather patterns, more unpredictable. Our summers seem to be getting hotter with heat waves. Last year we had, a heat wave with high temperatures like 118, 119. We're also seeing wet winters with atmospheric rivers. We had snow earlier this year, which isn't typical for us. So, MK was talking about how like loss of some of these survival supplies can be really impactful on our patients' health outcomes. And that's why we as a team have really tried to be intentional about how we're distributing some of these supplies. We carry them with us whenever we're doing outreach. We also have tried to get extra funding to be able to purchase not just the things that we normally hand out, such as like food and hygiene kits and water, but also to hand out tarps and sleeping bags and all of that kind of thing. Knowing that our patients are going to be losing these things at sort of increased frequency, we want to make sure that we're doing our part to get them resupplied. That way they don't have some of those serious health outcomes related to the weather. Storage of medications and critical documents. This is something that we've seen in our patients. Or we've seen this has been a strategy that's been helpful for us in mitigating impacts on our patients. We have a formulary within our department. We stock various medications, prescribed medications, and then we also have the ability to store our patients' medications securely. So that's been something that's helpful. If we know that there's an encampment sweep coming up, then we can essentially hang on to their medications if it makes sense medically. That way our patients aren't necessarily at risk of losing those during the encampment sweep. And then following up later on, once they land somewhere and have a little more stability, and then we can go out and take those to them. So that's been helpful. We do the same thing with our patients' critical documents. Our program director was really insightful when our community started increasing the frequency of encampment sweeps. And she utilized some of our funding to be able to purchase a PO box here. That way we can have our patients send their critical documents. We don't use that, across the board for all of their mail. But as far as like, mail from Social Security, critical documents like birth certificates, Social Security cards, that kind of thing, paperwork from HUD, they can have all of that sent to that PO box, and then our case managers will go and pick that up, and then we can store that securely in a similar way as the medications. So we've seen that to be an effective strategy. for helping people hang on to the things that they need to. And then developing street resilient treatment plans. That would be things like considering a long-acting injectable versus an oral medication, such as our antipsychotic meds. Hepatitis C medications, we do a lot of Hep C treatment up here. We do Hep C treatment on the street, but as we know, that's like an 8 to 12 week course of medications that we really want them to be taking daily, without a lot of missed doses. And so considering, you know, it could be something that you consider delaying treatment until they've gotten to kind of a place of a little more stability. Or figuring out a way to like store their medications, like a little bit of the course at a time, and taking that out to them, you know, on a weekly or every 2-week frequency. Next slide.
Yes. So another health consequence of encampment suites is that they lead to increased health risk and disruption of care. And this comes up in so many different ways, as that we see during street medicine. Exacerbation of health challenges, you know, being swept makes almost every chronic condition worse and creates new ones. And so like Kyle was saying, like when folks are swept and lose their medications, their access to hepatitis C medication, HIV medication, it disrupts the whole treatment plan, and it is really, really, really extremely disruptive. Another thing we see a lot of is folks losing access to their medications for opioid use disorder, you know, buprenorphine or naloxone. And I've heard folks say that they've lost naloxone in the sweeps and needed it and were unable to have it when they needed it to reverse opioid overdose. And yes, so lots of chronic medical conditions can get worse after sweeps because of this. Sweeps also lead to disrupted care continuity. And so, you know, as a primary care physician, spend a lot of time like coordinating specialty care, getting people into care. And, you know, when sweeps they are random. And so they could happen on the time where you've been trying to get this dermatology appointment for a couple of months, and the sweep is that day, and it's really difficult to get your patient there. And Kyle will kind of highlight a case of this later on. But yes, it just disrupts continuity of care. And also displacement affects patients and exposes them to environmental hazards and extreme weather. So, you know, Sacramento is just a little south of Redding, still very hot, so hot. And like I've seen sweeps happening, you know, when it is 100, it's hot, hundreds of degrees and just exhausted. People are physically exhausted, sweating, can barely move, have heart failure, like, and it's just, you know, the strenuous activity of moving everything that is important to you is exhausting. And also, you know, increases your risk of heat-related illness. And then on the reverse side, the cold side, I don't know, it's not cold here ever, but you can lead to things like frostbite, just not having access to your sleeping bag, etc. And sweeps take place in all different types of weather, whether that's snow, extreme heat, or rain. And so just being forced to move around and move all your belongings can result in a multitude of health consequences from that.
Yeah, so sort of the strategies for this is we know that, you know, encampment sweeps, like MK was saying, lead to increased morbidity or mortality in a couple different ways. One, they're just displaced from their regular spots, having access to the things that they need. And then two, it creates that significant disruption with us as their support team. And so really the strategies in this section are aimed at really just maintaining that continuity with them as they're going through this period of sort of increased displacement. So, you know, like we saw in the practice guide, there's this period of doing some prep work that's starting to think through like what's going to be impacted if my patient is going to be displaced. And that includes sort of thinking within the context of their various medical issues. So one thing that we have found helpful, you know, in order to stay ahead of the sweeps and to do some of that prep work, it is good to know like when sweeps are going to happen. And so we have tried to build some bridges with our local law enforcement agency. That way we can have some of that information ahead of time, and we can go out as teams and sort of triage our folks that are more vulnerable than most, try to come up with alternative shelter solutions, and then think through some of those, like, maybe coming up with like a sweep resilient treatment plan, or really just thinking through the details of like what would happen to my patient medically were they to be displaced from their regular spot and also to lose contact with me. So, on the flip side, we're also very careful, like we're very clear with our patients that the information only flows one way. We are receiving information from law enforcement about when they are doing sweeps and where. That way we can be more effective in navigating this, but we never disclose to RPD, that's our police department. We never disclose to them where camps are, or, we just try to be very sensitive to our patients' privacy. And I'll tell patients that, like, I'll tell them like, hey, listen, like, we know that a sweep is happening, but we receive that information from law enforcement, but we never, send information in the opposite direction. So in order to proactively develop a relocation plan with patients, you want to be triaging vulnerability, you want to problem solve relocation and assess safety, and then you want to plan for loss of communication. So in triaging their vulnerability, like one thing that we have utilized in our program, and we're an integrated program, meaning that we have fixed site, street medicine, medical respite, all under sort of like one department in our health system. So oftentimes with those folks that we feel are at increased risk of hospitalization related to getting displaced, then we'll consider an admission into medical respite for a short period of time in order to sort of like stabilize their chronic conditions, help them remain safe, and then come up with some sort of alternative shelter solution from there. Problem solving relocation and assessing safety. We have seen, like, as we've gone out and we've tried to like problem solve with folks, a lot of times, because our patients tend to remain within close proximity to where they normally hang out, where they normally stay. Oftentimes they'll relocate to a location that's not far from where they are, where other people may be camping, when in reality that's marked for an encampment sweep, within the same kind of timeline as the camp that they were just staying in. So sort of trying to mitigate this like displaced, and giving them sort of some breathing room in between to be able to like mitigate some of those health impacts. So, we never try to police like the camps. I've seen sometimes where like, outreach teams will really try to like not police, but sort of like help the encampment stay under the radar in like picking up the trash and doing some other things. We haven't taken that approach, but we do try to problem solve when our patients are considering moving and helping them get to like another place that would be safe. And then planning for loss of communication. That's coming up with a plan. Like if you lose contact with your patient, some teams will help patients get phones. Others will set up pop-up clinics or utilize fixed sites, that sort of thing. And then when you do lose contact with your patient, then how can you find them? How can you be intentional about adapting your outreach practice to be able to like reconnect with people? And so what we've done as a team is we've tried to expand our outreach hours. We've considered doing some night outreach. We've instructed our outreach staff to really consider how they're doing outreach. Whereas before we might have canvassed through larger encampments. Now we're encouraging them to look for people in, camping in smaller groups, to go deeper into the green space, to really be intentional about like looking in those places that people might be camping that's less visible and a little bit safer. I like this picture on this slide because this is Dr. Bear down in Bakersfield that kind of highlights this, right? Is, you got to adapt your outreach practice to look for folks as they go more underground as a result of like the sort of like recurrent displacement. Increase internal and interagency communication. We try to have a weekly MDT meeting with our various outreach workers and our medical staff that are doing outreach. And that way we can really just talk through who we're looking for, and then really utilize us as a team and expand our reach and being able to find people that are vulnerable. And then utilizing fixed sites and established communication lines to the street medicine teams. You know, our philosophy is we meet patients where we're at, like we are not mobile vans. You know, we like to have that sort of like delineated clearly. This may be a time where you might want to lean a little more heavily on some of your fixed sites, right? My patients that I see on the street, even though a lot of them won't come see me on our mobile unit, they know that I'm there every Wednesday. And so, you know, during this time, even though like, you know, our MO is going to them, it may be that may be useful where they know that if they lose communication with you, that they can at least come to see you there. And it may be that you are a street medicine team without other sort of like, you know, delivery models. And you could consider during this time, like maybe starting a pop-up clinic at a regular and consistent location where people know where you're going to be. That way, if you lose communication, there's something that they can sort of grab onto and say like, well, I know my provider is going to be there at this time. Next slide. So this was a patient, I thought this was a really nice example of, or not a nice example, I'm sorry. This was a really striking example of how encampment sweeps impact our patients. This is a patient of mine who obviously provided consent for me to share his story. I saw him a number of years ago. He approached us after several visits of us seeing another patient close to his encampment. He's got a history of psychosis, was somewhat paranoid at the time. Took us a little while to kind of establish trust and rapport. And he approached us about this mass on his nose, wanted to get it addressed. So I did a biopsy on the street, confirmed the diagnosis of skin cancer. We had arranged for him to go see dermatology at UC Davis in Sacramento for micrographic removal. And then subsequently his camp was swept, and then we lost him to follow-up for about like 9-10 months. And then when we were finally able to reestablish care, the mass, as you can see, had grown significantly. And it was invading and eroding into his nasal cavity, his sinus cavity. It was threatening both, but mainly his right eye. And we knew at that point we just like really needed to hustle and get this guy some care. Next slide. Fortunately, we were able to do that. We had the resources to do that. And we got him into our medical respite program so that we could have him in a stable place to be able to coordinate his care. We got him connected with ENT, a specialist at UC Davis, who recommended radiation therapy. He underwent 8 weeks of that. The mass shrunk. Unfortunately, had residual cancer even after like a sort of nose sparing surgery, and he had to have a total rhinectomy, so removal of his nose. But he's doing great. He's in permanent supportive housing. Our team continues to case manage him. He's stable on a long-acting injectable, teaching art classes at another sort of like transitional housing program. So it's both a cautionary tale about the dangers of encampment sweeps, which we all know, but then I think also a hopeful message that we can navigate this and still provide people with the care that they need.
Yes, in the interest of time, going to kind of move through this a little bit more quickly, but no less significant. Sweeps also lead to disruption of community and vulnerability to violence. And so mentioned about community is so important. And when camps are disrupted, that leads to people being dispersed, and that can create risk to the risk of violence increases. And this has been documented in multiple studies that when communities are broken up, when encampment sweeps happen, people have higher risk of violence. And community also includes pets. Pets are so important to so many people in the world and people who are living outside. And they provide crucial emotional support, companionship, and also offer protection. And so losing them is a huge loss. The physical act of being, things being picked up that are so important to you and thrown into the trash is alienating and dehumanizing, period. And that leads to a lack of trust in the system and other people, which leads to often sometimes healthcare and housing engagement difficulties. So sweeps just break trust in the system, and it's after camps have been swept, often re-engaging and kind of rebuilding trust is a key part of the response to that.
Yep. Okay, I'm gonna go through this kind of quickly because we are pressed for time. So I think the big question, though, I just want to point out, and we spent some time in the guide talking about this, is really beforehand you want to assess and determine what your role is going to be on the day of the sweep as a street medicine team. I can think of a time where I got called to assess a pregnant patient that was actively getting swept, displaced from her encampment. And I showed up to assess this patient, and all of my other patients were standing around saying, like, Dr. Kyle, what are you gonna do to help us? And in spite of me wanting to load everybody's stuff into our Sprinter van, like, we just didn't have the bandwidth or the resources to do that in a way that was like fair, judicious for everybody. So, you really need to take stock of what your resources are internally, what the how you want to advocate within your community, what the political climate is, how receptive like your city council and law enforcement agencies are, and then decide like this is what we as a team are going to do in responding and advocating. Is it going to be on the day of the encampment sweep, trying to like hold people accountable? Is it going to be behind the scenes? Are we going to focus on just providing good care for our folks? Yeah, that sort of thing. Avoid unfulfilled promises. Like, don't offer things that you can't do if you don't have the resources to be able to do that. Next slide. I don't want to gloss over our furry friends because they are so important. But just be intentional. Like MK highlighted that the loss of pets for our patients during a sweep is especially impactful. They are them's people for sure. So just like really be intentional about like coming up with some plans for the pets as well as your patients. And that can go a long way to like building trust with your patients as well. Next slide.
So sweeps also continuously lead to trauma and escalation of mental health and substance use challenges. And I said this in the report, but we'll say it again here, in that, in all of my medical training, encampment sweeps are one of, and if not the most traumatic thing that I've witnessed as a family physician. And this goes with kind of the dehumanization and just the disregard of people's lives and existence and things that are important to them. And just watching that happen, like Kyle said, it's like you have to depend on like where you are and how to handle that. And I am not living there. And so I can't even, begin to imagine how this results in the trauma for the people who are experiencing it directly. And it does. And people are, sweeps are extremely traumatic, and it makes life worse. And that can show up in ways like maybe increasing substance use, but to help deal with that trauma, but also sometimes substance use disorder or substance use can increase because someone's been moved to a new part of town and they don't know where they are and they need to stay awake in order to prevent themselves from violence that increases so it's all interconnected. And just the continuous trauma of not having a safe place to stay and the continuous threat of being moved is inhumane.
Okay. So really, we want to be advocating behind the scenes for a trauma-informed approach. We sent some of the studies and some information around that to our police chief here locally. We had the CEO of our health system do that. Unfortunately, haven't seen that reflected in how they're approaching encampment sweeps. But I think continuing to sort of like be consistent in how we're discussing with the policymakers around this. And then we really want to increase harm reduction education and safe use material. And then really be maintaining positive regards and provide emotional supports to our patients. Caitlin, do you want to talk briefly about the decampment report card? Caitlin did some really nice work in Canada around this. This is a tool that they utilize to sort of like hold their policymakers accountable when doing encampment sweeps.
Yeah, this was a fun thing we did. In the Canadian context, we worked with folks living in encampments to develop like a report card where folks could essentially grade their governments on the extent to which they were aligning their practices with their human rights, the encampment residents' human rights, and a trauma-informed approach. So encampments who were facing eviction would fill these out and then use the grades like D or F or whatever as an advocacy strategy, and it ended up being really effective and kind of brought some governments to the table that weren't willing to have conversations previously. So that's one tactic. There's a huge range, but that was something we did in the Canadian context that worked.
Okay. So reestablishing treatment and care. So you've prepped, you've done all the prep work, you've like come up with good plans for your patient, they've been displaced, and now how do you re-engage once you've lost contact with them? If you've been doing outreach consistently, really like that relationship should be maintained. We're not the ones doing the sweeps, we're the ones that are there to support our patients. And so in my experience, I've found that like patients, you kind of pick up where you left off. What I do think is important is that we're reassessing like their new living situation and how that's going to impact their health outcomes. And so house beds, that's a tool for taking a history that takes into account those various factors in our patients that are rough sleeping or unsheltered. This was developed by our friends down at USC in Los Angeles, as well as some others. And this is a really nice clinical tool where you can start thinking through, like, based off their new camping location, their degree of vulnerability and how it's going to impact their health outcomes. So, mainly the things that I would sort of point out are like income, salary or income. Do they have access to their regular panhandling spots? What's their food security like? Do they have access to clean water? Do we need to support them in some of these sort of more basic functions as they're settling into a new space? Okay, and then reconnecting them with the system, we're reconnecting with them in the services that we provide, but where are they on the housing list? Do they have a housing case manager within another agency that has lost track of them? Were they in the process of working with Social Security on disability? So, working with your case management teams or other agencies to like try and get them re-plugged back into like the continuum of care at large.
Yes. So in conclusion, I've said it every slide that I've talked on, but sweeps are harmful. They continuously cause negative health consequences again and again and again, and they're harming our patients, our people, our neighbors, and they contribute to early death. And that has been proven and that has been modeled in multiple studies and continues to show that by using this tactic of forcibly relocating people, it can lead to a 15 to 24.4 increase in death among unhoused individuals in 10 years, which is a significant increase. And we think about, a lot of things in medicine that have smaller impacts that we're doing a lot of, like screenings and things like this. But sweeps are contributing to early deaths in our neighbors who are sleeping outside. And the data here is on the side, mortality rates for folks in shelters is already 10 times that, more than those who are living inside. And unsheltered individuals are even at a higher risk than that. So 3 times the 10 times than those living in the shelter. And that is a extreme risk. And yeah, I'll pass it. I'll end on that. I'll pass it to you, Kyle.
Okay. One thing I want to highlight on this slide, with encampment sweeps, I think we're all learning a lot in how to navigate this. Myself as a leader of a program, I'm also learning how to help my staff navigate encampment sweeps and the impacts that it has on them vicariously. And so, sort of acknowledging the slide previously and the significant loss of life and health impacts, and the fact that I think encampment sweeps aren't going away anytime soon, unfortunately. Figuring out strategies and processes around how to keep you and your staff going, knowing that this may be more of a marathon and not a sprint, I think is especially important. Setting appropriate interventional goals and expectations. And that's not throwing in the towel. That's not sort of saying like, well, encampment sweeps are awful and there's nothing that can be done. We want you to take from the guide that there very much is a lot that we can do in this space. But setting reasonable and appropriate goals and expectations for us, I think, can help maintain our longevity, and oftentimes showing up for our patients and doing our job, even without sort of the added extras that we're doing around this, I think can oftentimes just be enough. And that's all we got.
Beautiful. Okay. Thank you both so much. Your expertise is so incredible in this space, and we're so glad you shared it with us. And I'm really, really excited to invite John and Emma to provide some of their comments and lessons learned. I think we'll start with you, John, if that's okay. Would love to hear your thoughts and reflections.
Okay. From what I've gathered, Kirby on the Boulevard here in Kansas City, what they've done, I guess now what they're doing now is calling what they call a closure with support, when as the police department generally give us 30 days notice before a sweep happens. So with our case management, trying to get them unhoused, set up with some kind of housing or shelter, so that they're more easily tracked and be able to spot and care for medically. They also collaborate with other outreach groups and try to document and track where individuals are going, or direct them to one of the 9 clinics that we have throughout Kansas City if we lose track of them. But of course, like you stated, we try to get cell phone numbers as much as possible, because there's always that loss of communication. Supplies, transportation for some of the older folks that are having difficulty moving their supplies. And that comes directly from what I could experience when I was going out of my 40s into my 50s, and the arthritis is kicking in, and I spent 6 months gathering supplies for my tent, and then being noticed or notified that in 30 days I'm pretty much gonna have to abandon it all because I can't carry everything by myself. So we tried to, as unhoused individuals, always keep an eye out during the year for other locations that might be available, which is something that many of the outreach people can do, because they're always looking for individuals in different campsites, but they could also keep a mental track of, this might be a good area for somebody, or but a lot of times the city doesn't want the homeless to get comfortable in one area, or uh, what would you call, make any kind of a permanent dwelling there. And then also, of course, the hoarding of things becomes overwhelming. And when it's can be seen by the public, that's generally when a lot of the sweeps takes place. It's also a fire hazard sometimes. You have so much stuff surrounding each individual's tent. So I understand what the city's doing, and they've made better efforts here in Kansas City to at least notify, give notice, and I've seen policemen even help some individuals too. So it's a good thing. But that's what we're doing here in Kansas City, and trying our best to help individuals and keep, the medical issues that our patients have at the forefront of everything we do. So
Beautiful. Thank you so much, John. So, so wonderful.
absolutely,
I know folks will have questions for you too. So
sure.
thank you for sharing. Um, Emma, I'm going to throw your slides up and we can get started with your reflections. Just a second.
Thank you so much. Yeah, I was brought onto this panel to speak a little bit about my experiences with encampment advocacy and my experience both on the ground at the city level and at more of an advocacy level. And so I'm going to briefly talk about that and some of the lessons that I've learned in doing this work. And I will say that I've tried a lot of different methods, some of which were discussed already. Most of the time, these are have left me feeling discouraged and disillusioned, disheartened by the reality of our folks on the street. And um, I still struggle with this. And I think that we're not here to say that there's a solution that is working for anyone necessarily, but we have to try. And so I just want to talk about some of the ways that I've tried and some of my experiences. So this is a photo of a little bit of graffiti at an encampment clearing that's been cleared at least 6 or 7 times, the same two clients that I work with. And if not here, then where, I think just captures a lot of the sentiment around what's going on in our city, which is in New Haven, Connecticut. And nationally, there's no real other alternative for people to go to. Next slide, please. But this is also a picture of myself and my clinician, Eileen Hamill, who we were called to an encampment clearing. Mostly, we decided that we would attend, although later we've decided that we no longer feel that we should be attending encampment clearings for risk of showing endorsement for the process. But this was a particular case of a client that was hoarding and had quite a lot of bags. He was near a school and was told that he couldn't be there because it was attracting too much attention. So we arrived and helped him before the clearing was supposed to start to help him move his stuff to a different location. However, when the city officials arrived, we asked them like, where can he go? And of course, they said nowhere. That, there's no legal place for him to go if you put his stuff on this other side of the fence, which is pictured here, where you can see all of his stuff packed away in bags. It will still be cleared away. And so we spent hours with gloves on, like helping him organize his stuff, decide which stuff to keep and which stuff to throw away, and moved it all to this other side of the fence, which was no longer on the school property. When the next week they came and cleared this as well. But I think what I felt was important about that allyship, and I think it's not necessarily wrong to be hands-on in an encampment sweep, was that we were there for our client and he recognized that, and we were clearly on his side when others were threatening with literal bulldozers at his doorstep and trying to clear him away. So I felt like that was something really valuable about being there, was like the allyship and support. Um, but at the same time, I was also asked if I could paper him to send him to the hospital in order to facilitate the encampment clearing. And as a psychiatrist, that's completely inappropriate, in my opinion, and would just be sort of endorsing the system. And so I said that was not appropriate. But other things that we've done, I guess, in terms of on the ground allyship with our clients is telling them at the first meeting that we are not with the city. And I think that telling people that explicitly, I've learned, helps sort of prevent people from misunderstanding our role, which can be difficult when we are outreach workers, there are other outreach workers, and there are city outreach workers, quote unquote, that approach them at different times with very different agendas. And so making sure we announce that we are not in that situation. We do not report encampments. If your encampment is cleared, it is not because we reported it. And these are some tips so that you don't attract attention to yourselves, and hopefully that can help you prevent from being found out. So next slide, please. And then on the second level, I guess, is like at the city level, we have taken a lot of pictures of these signs, which are these notices to remove personal property. And something that we found, and I think this can be helpful, is to try to get an in with the people that are actually posting encampments so that you at least know ahead of time when it's going to happen. And so we keep track of these and try to keep the city accountable, where we might find an encampment that was cleared without being posted, or we might have a patient report like my encampment is gone, but I never knew about it. And so like responding to these kinds of complaints and giving the city feedback that like they're not following even their own protocol, which is quite aggressive. They will post an encampment and then the date of clearing is within 72 hours, or it's 72 hours later. So there's really very little time for people to gather their belongings and or for outreach to even find the person and try to come up with an alternative plan, unfortunately. But I like this approach of kind of like trying to expose and hold accountable people that are in power of doing this. Um, and uh, I guess similarly, people mentioned police. I think we have been able to ally with our police force and sort of say, even if police are called to the scene, they are not going to look the person up for a warrant. They're not going to arrest the person for trespassing or cite them or anything. We've had some good experiences with police in that way, although we have also had people who do get arrested because of like breach of peace issues that come up during the clearing for people with mental illness, unfortunately. Next slide, please. And then kind of on a bigger level, I would say some of my experiences have been trying to advocate for our clients and determining what my role is as a psychiatrist, as a care provider, as an outreach worker to people on the streets, while also sort of keeping my job and also not burning out. And so this is a picture of one of our op-eds that was published in the fall. And I actually really hesitated to do this because a different op-ed had resulted in, I feel, retaliation by someone that was sort of pointed out in the op-ed as doing aggressive clearings, which was the State Department of Transportation at the time. And in response, instead of collaborating with the people that wrote it, which wasn't myself, they aggressively increased their clearings. And so I was really afraid to write something because I was afraid that it would like lead to retaliation. So it's very carefully drafted and written to not point out any particular party, but still leave them with food for thought and medical evidence that of all the harms that we've just been discussing. Secondly, we've actually had meetings with our city, and these have oftentimes been met with sort of like, well, our city does not condone outdoor living, and sort of the circular argument of like, well, we can't allow people to camp on sidewalks. We can't allow this. There's like schools and blah, blah, blah. And there's all these complaints. But I think having, at least being able to have that conversation is really helpful for just yourself, I think, to be able to be like, I'm at the table with the people that are making these decisions, but also like understanding like why they're doing this. And it oftentimes still makes no sense, but at least to be in the conversation to be like, wait, you said that you're clearing encampments because of health and safety issues, but actually this encampment wasn't cleared for a health and safety issue. Can you clarify and maybe like create a policy that distinguishes different encampments for were cleared for different reasons? And so we're like at that level right now with our city and trying to maintain a relationship so that we're not completely alienated and lose our voice. Next slide. And so in a sense, that brings me to this other point about advocacy and activism. And these are some protests that have been happening on our public area, in our public areas by amazing, amazing people, most of them with lived experience or currently unhoused. And I've debated whether to like be in front of the bulldozer, holding a sign, shouting, and like making the news. And so for me, at least personally, that has not been the best role for me. But I've been actually sort of an informant to this group to explain like this is the city's new policy. Can you uh, notify the press of this? And then they might have a protest related to that. They might actually come to an encampment clearing to bear witness and sort of hold people accountable at the time of the clearing. And sometimes they have resources to help people with storage of their stuff, which we don't always have. So that's one role that can be really helpful, is like being an ally to the advocates and like helping them do their work better by being on the inside and having some knowledge of like what's actually going on. Next slide, please. I can't take credit for this, but this is just an example of some legislative advocacy that's been done to sort of like counter protect people's rights on the street. And so I wrote testimony in support of this and tried to get everyone I know to write testimony in support of this as well, to protect our unhoused friends on the street from sort of legislation like the Grants Pass outcome, which has led to a lot of criminalization policies. And similarly, I guess one other thing that I have kind of learned from this, I guess, is that the learning what the system is to be able to work against it. Just for example, with our city, one of the main reasons why they clear camps is because of excessive complaints that are posted through this online mechanism that's like really horrible. But you can just kind of like log in and anonymously post like, I don't want this encampment near me. It's in my neighborhood. And the result, unfortunately, is that it goes directly to the city worker who then clears the camp. Um, and but we realized that like they actually aren't interested in like clearing camps necessarily. They're interested in public opinion politics. And if we can find people that will counter complain and say, no, actually, I want this person in my neighborhood. They're causing no problems. And so that's like one of our upcoming strategies, is to flood this system with other voices that will counteract, to work within the same system that the city has identified as the reason why they're clearing camps. So just some examples of like how you can kind of try to not alienate the people that you want to actually have on your side, to be able to get the information, to be able to like maybe modify the policy in a little bit more of a favorable way. And next slide, please. And last, I'll just echo what some people have been saying, is that this is a major source of burnout for me and for other people. It's very just disheartening to see and very difficult. This was a picture taken by myself on one of the coldest days of the year, showing the signs from the Department of Transportation that they were going to clear the site. This is after the site was cleared. And we were driving by looking for our clients. Like we waste so much time just like trying to find people again. We just finally stopped and we're just like, okay, maybe they're here somewhere, and we'll just wait in the car because they know our car. And then we realized, like, we went closer and realized like that's them. They're like lying down on the bare ground. They no longer have a tent. They're just lying among their like residual belongings because they had thrown away all their sleeping bags, tents, everything. And we went up and they were freezing, freezing, freezing cold. And we like luckily had blankets to cover them up with, but it was just a moment of like sort of feeling like this is so unjust, this is so wrong, and like there's nothing we can do about it in some ways. But um my I guess I don't know, take home is that there's many things that can be done, and it's just a matter of like what feels right to you. It can be like going to the clearings and standing in front of the bulldozer. It can be through writing. It can be through maybe research, data collection, sort of proving things that are not evidence-based, and or maybe being strategic and incremental. So there's many ways that you can be involved and make a difference. Every community is very different, but just wanted to share some of my experiences with this, and happy to talk to anyone more, but I know we're running out of time, so thanks for letting me be here.
Oh, beautiful.